Well. Good morning. For those of you who stuck around, I appreciate it. This is Dr. Earl Stephenson Jr., your Atlanta board certified plastic surgeon, and I'm here for another Saturday. I am so sorry. First, we are late. I have a special guest for us, but technology is something. For the first time ever, I use a third party app. I'm not going to name them out. I'm not going to call them out. When we were set to go on at 11 o'clock, they had a bunch of traffic and they didn't have enough resources. So they had to effort resources to get us on. So we started off with a little bit of frenzy, but we made it. We're here. I hope you stuck around, and we're glad to have you here because today it is a special day. I would like to have my second guest on for this particular format. And today we have a guest. And if you're interested in weight loss, you're interested in wellness, we have Dr. Michael Kissel on. He's going to join us here in a few minutes. And we're going to talk about all things wellness, all things weight loss, and we're touch on all the hot topics. So I want to introduce Dr. Kissel. He's been gracious enough, and I've been lucky enough to get him on. He and I have known each other for a while, and we'll get into that a little bit. But he is a board certified anesthesiologist. He also does pain management, and he also does weight loss and wellness. He is a native of Atlanta. He's happily married with a beautiful family, and he is currently practicing in East Atlanta in Loganville, Georgia. So, with that introduction, I'm gonna let bring Dr. Kissel on, and we're gonna get into it. I would love for you guys to ask questions of us. This is what it's for. We're presenting this for you. So jump in, ask questions. So without further ado, let me introduce Dr. Kissel. Hey, Doc.
Hey, good morning.
Good morning. Can you hear me?
I can hear you.
Awesome. Thank you for your patience.
No worries. I
The
understand. Like you said,
gremlins were in the
technology is
building for
something.
sure. So,
Yeah, I
man,
really appreciate you having me on.
Of course. My pleasure. And I hope our guests loved this segment because I think you have a lot of information, a lot of the hot topics that we see circulating around. You're right in the middle of that. So, but I want to kind of start where you start any story in the beginning. So tell me a little bit about, how you got into medicine and kind of take us through your pathway to where you are now.
Okay, great. So, like you said, I grew up in Atlanta. I grew up in Gwinnett County. And from an early age, I wanted to be a doctor. I like science. I like to figure out how the body works and just enjoyed that stuff. And so that pathway, from the time I was in high school, I was taking AP science classes in college and just preparing for the pre-med route. So got into medical school. I went to Saba University and then did my internship in Memphis at UT Memphis, and then my residency, including a chief resident year in St. Louis. And then having grown up in Gwinnett County, wanted to come back to this area to practice. So was fortunate enough to get my first job out of residency at Eastside Medical Center at the time, Emory Eastside,
Okay.
in Snellville, Georgia.
Okay, awesome. Hey, so I mean, this is gonna be great for me because I know we've known each other for a long time, but I'm gonna learn something, and I've already learned something. So I didn't know you went to UT Memphis.
Yeah. I did
So
my
so I,
internship there at the Med.
so I did my internship at UT Memphis. It was kind of broken up at the time. It
Uh-huh.
was what is that? It's on Union Avenue. It was
There was um, there was
Methodist.
Baptist at the time, Methodist.
Methodist. I was at
Yep.
Methodist. I did my
Yep.
internship at Methodist Hospital.
Wild.
That's crazy. I mean, we've known each other all these years and we didn't know we might have crossed paths at some time. So
We
that's
may have.
crazy.
Yeah.
That is really crazy. So good stuff. So you said you were a board certified anesthesiologist and you trained in St. Louis. Is that what I understand?
Correct. Correct. At St.
Awesome.
Louis University.
Perfect. And that's how we met. We met at Eastside Medical Center. You
Right.
were kind of freshly out of training and new to the area. I'm a little older than you, so I had a little bit more experience. I was about 2 or 3 years into my practice, and we met at Eastside, and you provided, tremendous anesthesia for my patients, and we built a good relationship from there.
Absolutely. Yeah.
So, with that in mind, you provided anesthesia for quite a long time. Obviously, I'm a surgeon. I offer anesthesia for my patients, of course. But in my world, there's a hot topic, awake surgery, whether it's liposuction, facelift, whatever. And I'm not here to talk about awake surgery, but what I'm here to talk about and kind of get your opinion about, a lot of my clients are really afraid of anesthesia. So,
Sure.
one, could you talk to us about, the safety of anesthesia, how that safety is provided, talk about pain management during and after,
Yeah.
anesthesia, and maybe in anything else that you think is important that patients and clients should know to kind of break down some barriers.
Great question. So, anesthesia is probably the safest part of medicine.
Okay.
We make it look easy. People are afraid of it because of movies like Awake, where
Right.
we sensationalize the bad stories, and that's typical with any medicine, right? You almost
Sure.
always hear the terrible events that happen to people versus the good ones. So,
Of course.
in Atlanta, most anesthesia are provided in a care team model, meaning there's an anesthesiologist or a physician who is supervising or medically directing an anesthetist, whether that's a CRNA who's a nurse anesthetist or a PA, which we call anesthesiology assistants, who are sitting at the head of the bed the entire time, taking care of your anesthesia.
Okay.
For the vast majority of patients, especially in plastic surgery, where typically you're dealing with healthy patients, these are elective procedures. They're coming in, ready to go. The risk of having a complication from anesthesia is probably 1 in 10,000 or less. It's
Okay. That's
very, very,
yeah,
very,
pretty
very
low.
rare.
Yeah, really low.
Even while I've been practicing, so I've been an anesthesiologist since 2008, out
Okay.
of residency. We've seen advances in nerve blocks and things like that that allow us to better control pain and give you less anesthesia either by gas or through your IV, so that you can do more kind of awake-ish or what we call MAC or sedation type anesthesias, and still control your pain. Because bottom line, that's what anesthesia is about. It's not just being unconscious, it's not having pain during surgery.
Right. Right. Right.
So that's where we, with the nerve block technology, with ultrasound guided nerve blocks, um, advances in the type of anesthesia that we use through IV, we can use less gas, which often causes nausea and those things that make people uncomfortable after surgery, and do more IV anesthesia, nerve block, light sedation to moderate sedation, and get patients through that comfortably. Now, if you have patients that are terrified of surgery and hearing anything or being any wake at all, of course, we can provide a safe anesthesia where they're completely under, as if they were having their gallbladder removed.
Gotcha. Gotcha. So what I'm hearing from you that you have kind of ancillary other techniques besides gas in the IV that can help kind of keep people comfortable and actually help them maybe wake up a little faster and maybe
Of
feel a little
course.
better. Is that kind of what I'm
Absolutely.
hearing?
Yep.
Okay, awesome.
We've
Awesome.
seen, advances. There's, the big push with the opioid crisis of trying to get physicians, whether it's surgeon side or anesthesia side, to use less narcotics.
Right.
And so because of that push to not have to give people as much pain medicine after surgery, we've seen this rapid growth in nerve block techniques and other types of anesthesia, what we call multimodal anesthesia, where we're hitting a bunch of different receptors to control pain versus just throwing Percocet at it, or fentanyl in the operating room, so that patients wake up much more controlled from a pain standpoint, but also without as much nausea and vomiting and sedation and losing 3 days of their life because they're still
Sure.
in a fog.
Absolutely. And I think we kind of have echoed that and mirrored that a little bit. We might be a little bit behind in plastic surgery, but we have things like Exparel, which is a prolonged Novocaine that we inject into the muscles, particularly for tummy tuck. There have been some studies in the literature from my side that are using that for breast surgery and some other things, but we help as well kind of keep things under control pain wise, which allows you guys to deliver a little less medication, but everybody's still comfortable and people can wake up a little bit better, have a little less nausea.
For sure. And that,
Perfect.
the nausea is what destroys people post-op.
Yes.
They've had their surgery, they're feeling great about that, but when you just feel yucky and you're throwing up, that's not pleasant for anybody, whether you've just had surgery or not.
Absolutely, absolutely. So talk maybe a little bit more specifically about what you guys do for nausea, maybe before surgery, during
Yep.
surgery, and then after.
So, limiting narcotics is important. Limiting how much anesthesia gas you can give. So, if you're using other medications either through the IV or by mouth before surgery, that helps. Scopolamine patches, which people are often familiar with from going on a cruise ship or a
Sure.
fishing boat, we can use that behind the ear.
Okay.
Zofran, either by mouth beforehand or IV during the anesthesia. Decadron, which is a steroid. All of those things kind of add on and are hitting multiple different receptors because nausea happens in our brain. We think of it as a stomach problem, but it's really
Right.
happening up here in our brain. And so
Interesting.
if we can control some of those receptors in the brain, we don't see as much nausea and vomiting after surgery.
Awesome, awesome, awesome. So yeah, there's a lot of things that we can do to make this pleasant for everyone.
Absolutely. Yeah.
Perfect. I know another thing that my patients have mentioned to me in passing, or clients mentioned to me in passing, that they're afraid of. They're afraid of waking up in surgery. And then excuse my ignorance. I used to sit back there in my little area as you guys are putting patients to sleep, and I see you put on this little monitor, looks like a band-aid, and I think you guys called it a BIS monitor. Now
Yes, Mark.
I
Yeah.
may be mispronouncing that, but
Oh,
could
that's
you
right.
explain what that is and how that plays into keeping people awake or making sure that people are staying asleep?
Yeah, let me start with the most important part, and then I'll get into
Sure.
this. The chances of a healthy patient in an elective surgery becoming awake during anesthesia is probably 1 in a million or less.
Wow.
I mean, just exceptionally rare. The
Sure.
most common times that we see awake anesthesia issues are when the patient is having a traumatic event, such as a gunshot wound, where they are so unstable that anesthesia gas makes your blood pressure go down. So when we turn that
Okay.
gas on, all the blood vessels kind of dilate. That makes the heart have to work harder. And if you're in a traumatic event, your body's not going to do that. So number one for anesthesia is keep you alive. Number
Okay.
two is keep you asleep. So in a trauma, our first goal is to just make sure you're alive. And if we're not able to do that with anesthesia gas, we're going to have to use other things. And those are the situations where most commonly we hear people say, I woke up or I was
I
aware under
see. I
anesthesia.
see.
Exceptionally rare in elective surgery. I've never had a case. I've performed tens of thousands of anesthetics. Never had a case of awareness. Now, the other place that we commonly hear of awareness is in cases where maybe the anesthesiologist didn't explain to the patient what to expect as far as anesthesia. So, for example, foot surgery. A
Okay.
lot of foot surgery, podiatrists, we do those under sedation where the patient had the anticipation that they were going to be asleep, but really we were planning for them to be sedated. So they'll say, I woke up during my surgery. And then I'll say, well, what kind of surgery was it? I was
Right.
having a bunion repaired. And then
Right.
I have to educate the patient. Well, that's common. And that's just setting expectations.
Gotcha. Gotcha. And that's for everybody. Everybody has to set expectations so people have can kind of have the right experience in my mind and kind of say, yeah,
Yeah.
that's exactly what they told me, and that's exactly what
Yeah.
happened.
And then the BIS is just a tool that we use. It's called a bispectral index monitor. It is like a band-aid that goes across the forehead and it measures brain waves and it gives us a number that basically estimates your wakefulness. So
Okay.
it's just another tool that we use. There's a lot of tools in anesthesia that we use to kind of
Sure.
judge your level of anesthesia, but BIS is one of those tools.
Okay. Excellent. Perfect. So what I hear is anesthesia is safe. If you're a healthy person, let's say undergoing plastic surgery, waking up during surgery is so remote, it's just not even on the radar. So if you're healthy, you're going to have a safe anesthetic, you do well, there are medications and modalities to kind of help you have a great experience.
Yeah, exactly. I
Perfect.
mean, it's just so rare. Now, there's advances in plastic surgery too, where I know some plastic surgeons that are doing breast implants under sedation. So that's a place where the surgeon on your end and the anesthesiologist on my end have to say, hey, there may be a moment of a wakefulness, and if you kind of are uncomfortable, you let me know and I'll make you sleepier. And some patients want that, and other patients don't.
Absolutely, and every practitioner is different in the practice of medicine. That's why it's called the practice of medicine.
Yeah,
I train under my mentors. We did kind of sedations for tummy tucks and maybe
yeah,
some breast arc, but mostly tummy tucks. Where they gave them kind of the milk of amnesia. I think you guys call it
right.
propofol. And it
Propofol.
kind
Yeah,
of drift off. We do what we need to do, and there may be slight bits of wakefulness, but patients were mostly comfortable and they don't remember.
yeah.
I'm a little bit old fashioned. I like good old general anesthetic so that I can do what I need to do. But my point is you guys have many methods to keep people comfortable and safe.
Yes.
Perfect. Perfect. So you did anesthesia. I'm gonna switch gears a little bit. You did anesthesia for quite a while, and you and I were in the same hospital slugging it out. And then you also did pain management. So maybe talk to me a little bit about that. Is that something that all anesthesiologists do? Does it require special training? So educate me and educate the people.
So pain management specialists are typically come from one of two or three residency pathways. It's either anesthesia, which obviously that's what we do. As I mentioned, pain is an important part of our job.
Sure.
Physical medicine and rehab, which most people think of as sports medicine. And then
Okay.
psychiatry is kind of a third kind of offshoot that does pain management. So when I started doing anesthesia, the group that I was working with asked me about a year in if I would be interested in helping them in the pain clinic and seeing some patients so that it would, allow them to expand to another office and to give those guys that were in the pain clinic more opportunities for vacation and to shift our cycles
Okay.
around.
Right.
So my residency, I was fortunate that I was very heavy in pain management rotations anyways. We did a lot of nerve blocks, a lot of pain clinic rotations. And so I was
Okay.
comfortable with that. And I was like, sure, let me, broaden my horizons. So I
Sure.
went back and did some, extra long weekend courses, advanced training, tutelage under the two other physicians that were there who kind of took me under their wing and taught me, their techniques. And, again, it's the practice of medicine. You're always
Sure.
learning. You're always, tweaking
Absolutely.
what you're doing. So I started doing about 80% anesthesia, 20% pain. And I did that for the next probably 13 or 14 years of my career,
Wow.
balancing
Wow.
anesthesia and pain.
Wow. 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 And so there you did those things in conjunction for 13, 14 years, and then you took another pivot. Is that correct?
Yeah.
So
Pivot.
now you are out of the hospital and you have your own business. So maybe talk about that
Yeah.
transition and what inspired that transition and where you are.
So at some point, I think around 2016, I became the head of the anesthesia department at Eastside. And then in 2020, that year will stick in everybody's mind, I became actually the chief
Sure.
of staff for the hospital. So
I'm sorry.
started in January, not knowing what was coming. So I was the head of all the physicians really in the hospital. So I was balancing working with the administration side of the hospital, the CEO, the COO, the nurses, and the medical staff. And then COVID hit. And so I was really on the front lines from an anesthesia standpoint, taking care of very, very sick patients, not
Sure.
just in the emergency room, but in the ICU, and working with the hospital administration to figure all that out, learning what we didn't know, and planning for the worst and
Sure.
staffing and all that stuff. And just to be very honest, I got a little burnt out.
Of course.
I got 2 years into that. It was a 2 year cycle, and I said, I'm not healthy myself anymore, and
Mm.
I just got to do something different. So
Right.
I prayed about it and I thought about it and I talked to my family about it. And this was going to be a big leap if I did
Yeah,
this.
of course.
And found a spot in Loganville, put in an offer for it, and it went through. And I thought, okay, well now I have to quit my job. I got to
Yikes.
tell the hospital, yeah, I'm going to
Right.
leave a good salary
Right.
and go grind. And it's if I've got to do it, and when nobody's paying me, I get paid by insurance companies, and
Sure.
so that was a leap of faith.
Of
So in
course.
2022, I opened up Southern Comfort Pain and Wellness in Loganville.
Awesome, awesome, and things have been going smashingly since that time, correct?
Great. Yeah, correct.
Awesome, awesome, awesome. Yeah, I mean, 2020 was, you know, it was a heck of a time for everybody. It really gave a lot of people, I think, especially physicians, pause as to what they were doing with their lives. Is this what they want to do? And our lives are kind of always a little bit in jeopardy, but that really kind of, in my mind, put my mortality at my front in front of my face,
Yeah.
and and made me kind of think about my life and what I was doing. So I can certainly understand that, and so I'm happy that you made that transition. It looks like you're happy. And so now
I'm
you are the CEO, boss, doctor, foot soldier at
yeah,
Southern
I'm the
Comfort.
HR person, the payroll
Yeah,
person. Yeah,
yeah.
yeah. I
At,
do
at,
everything. Yeah,
at Southern Comfort Pain and Wellness,
yeah,
correct?
correct.
Okay, so now tell me, you've taken a lot of that same training and experience over the last maybe 2 decades and brought it to your practice, and you focus on pain and you focus on wellness. So what's that really mean in a
Yeah.
private practice?
So for the pain side is obvious. The vast majority of my pain patients are neck pain, back pain. I do joint pain. Again, there's some nerve blocks that we can do before people have total knee replacements that help with post-op pain for several months. And then the wellness side of things started with me saying, people after 2020 with COVID were really focusing on, you know, I want to get myself, life is short. We saw
Yes.
people die. Your loved ones that were
Yes.
otherwise healthy passed away. And so people were saying, hey, what can I do to get to feel better? So I started with like IV vitamin infusions. People were worn down. I still had people coming in post COVID that were just exhausted. So we did some IV infusions. And then at the same time, I started on the semaglutide wellness journey of losing weight.
Okay.
And then patients started seeing me lose weight and they were saying, well, how can I get this? And I wasn't even offering it as in my clinic. It was just me on my own journey.
Oh, okay. So this was just you. You
It was
decided
me.
to take it personally.
Yeah.
Okay, got it.
Yeah. I
Got
had
it.
a nurse practitioner reach out and say, hey, I can get this new medicine. And, I've struggled with weight my whole life. And so I was like, okay, let's try it. And then all of a
Sure.
sudden I was like, wow, this is a game changer. And then
Okay.
patients were saying, okay, well, how do I get this? And I was like, well, I don't really have, talk to your primary care doctor.
Sure.
And then it became so many patients say, hey, let me get this medicine. I had to figure out a way to be able to offer it to patients.
Gotcha, gotcha. So, yeah, and this is a great segue because I mean, right now, semaglutides are hot. I mean, you see commercials everywhere. You see people
Yeah.
talking about it. So you touched on it. So maybe just from a historical point of view, just briefly,
Yeah.
talk about semaglutides because I don't think they're new medications. They're
Right.
medications that have been out there, but now they have a different kind of indication. So maybe you
Yeah.
can educate us a little bit about that, of how we started and how we got to where we are now.
So this class of medicines are called GLP-1 agonists. And they were developed for diabetics because they stabilize insulin. And one of the problems that diabetics have is their sugar goes up and then the insulin kind of gets spit out and then they're crashing and they're up and they're down. And
Okay.
that's not healthy for your body to deal with all these swings. So the drug class was developed for those patients to kind of keep their insulin more stable throughout the day. And
I see.
then a couple of cycles of those medicines came around, and all of a sudden, these patients were reporting weight loss. And the
Hmm.
drug company went back to look at the molecule and go, okay, what's happening here? Why are we seeing these patients lose weight? We didn't develop this drug for that. A lot
Right.
of drugs are like that. Viagra
Sure.
was developed for heart failure. And then these old guys were coming into the doctor going, well, I don't know about my heart, but I got
Yeah,
other
but
things that are doing better.
yeah,
And,
right.
Latisse was developed for glaucoma. And then the patients were
Sure,
talking about their
eyelashes.
eyelashes were beautiful. So a lot of medicines happen that way. And this is one of them. So they went back, they looked at the molecule, and they realized that it does a lot of different things in the body. But the three most important that I talk about, it inhibits the hunger center of the brain. So that part of
Okay,
your brain that makes you think about food and tells you you're hungry, it kind of turns that switch off. A lot of
okay.
people describe it as food noise. So those people, and I've struggled with it personally, where you plan your vacation around where you're going to go to dinner, or you
Right.
wake up in the morning and say, what am I going to eat this afternoon when I get home from work? It kind of
Sure.
flips that switch off where you're not thinking about food. It
Gotcha.
improves fat metabolism, and then probably most importantly, it delays gastric emptying. So when we eat, food gets churned up in our stomach, and then we move it into our small intestine. This slows down that process of transferring food from your stomach to your small intestine. So when you're eating, you get full a lot faster, and then you stay
Okay.
full longer. So you don't eat as much because you can.
Gotcha. Gotcha. Interesting, interesting. So, if someone is struggling with weight, and we all struggle with weight, I struggle with weight. Uh, and how would someone know where to start? Do they start with semi-glutides? Do they start with diet and exercise? I mean, it may be different for different people.
Yeah.
How do you start someone on that journey?
Yeah, so everybody's journey is different. I've had patients who her daughter was getting married, and she's like, she wasn't that heavy, but she's like, I want to lose 10 pounds because I want
Okay.
this one specific dress, and I wanted it to look this way. So we put her on it. She lost 10 pounds over the course of 6 weeks. She went off of it, and that was her goal. That was it.
Okay.
That's all she needed.
Gotcha.
For patients like me who have struggled, I weighed over 300 pounds at one point in my life. I've done every diet known to man. I've exercised. I lost 100 pounds at one point,
You look
running.
great, by the way.
Yeah, thank you. Yeah, but then I had an injury and I couldn't run for several months. And then you get out of the habit of running, and slowly that weight crept back up. And so this is the first time with this medicine where I started it and have sustained weight loss. I've been at the same weight now for over a year,
Okay.
maintaining myself on a micro dose, a very, very tiny weekly dose of this medication. So typically when patients come to me, I talk to them about what are their goals? How much weight do
Sure.
you want to lose? Is this a long-term thing for you? Have you struggled for weight, or did you have an accident and you had a knee injury or something, and you just need help kind of getting your weight back off, and then you can go off the medicine. So I talk about their goals, and then typically we start at a very low dose and then slowly increase as needed to get their weight loss where they want it to be.
Gotcha, gotcha. And once they have achieved that weight loss, do you taper them down? Do you take them off? How does that look?
Some patients want to take a break, and I have patients that say, you know what, I miss being able to eat, a burger and not,
Right,
just a third of a burger. So they'll take a
right.
little break, and then,
Okay,
they may, if they creep back up, they may come back. This is a medicine that you can go off and on. You don't have to taper. You can just stop it. There's no ill
okay.
effects from just stopping it. Um, People like me, like again, being heavy my whole life, I don't want to risk putting on 80 pounds again. So I
Sure.
just kind of wean myself down slowly and found a dose that worked for me to where I can maintain a weight. So I'm
Got
taking 5 units a week, which is 0.25 milligrams of this medicine, teeny tiny once a week injection. And that seems to have worked for me to kind of keep my weight where I want it to be.
okay,
But
okay.
I have patients whose maintenance dose is 15 units. So, everybody's body's different. So we
Gotcha.
just find their maintenance.
You find that sweet
Yeah,
spot for them, and you can keep going. Okay,
correct.
awesome. Um, I had a question and it just escaped me, of course. So let me ask you this: Is diet and exercise or healthy eating, healthy exercise part of that, included in that, or is it, one or the other? I know that sounds like a silly question, but do you try to marry some other strategies?
It can be. So for
Mhm.
most people, when you're 280 and you go to exercise, you can exercise for 5 minutes and then you're miserable. You just got too much weight on you. So a lot of my patients, I say, why don't we hold off on the exercise? Let's get 15 or 20 pounds off of you, and then let's start an exercise program. Because one of the things that happens with weight loss is the motivation. So when you
Yes,
step on the scale and you're 280 and you're like, I'm miserable. I don't feel good about myself, and then you
yes,
take some semaglutide, and a month later you're down 10 pounds, and that first number or the second number, instead of being an 8, is now a 7.
right,
That you build on that, and now I see people like, okay, well, now I started walking, and then I see them a month later and they're down another 5-10 pounds, and they're like, now I'm running, and now
right,
I'm
right.
lifting weights, because and then it's snowballing that weight loss. So you've gone from not just calorie restriction, to exercise, and from exercise, now I'm making better choices about what type of foods I'm eating, because I figured out this new stomach that I have. And so I see
Right.
people that really do well because that snowball just, and then before you know it, the first number is no longer a 2, it's a 1.
Right,
And that's
right.
huge. Just
Yes,
mentally, that's huge for
yes,
patients.
yes. That's interesting, and you use mental health, and I'm kinda keen on that. I didn't think about this, but it's just good discussion, and maybe you can speak to this. I know you can. Yeah, obviously, when people are not feeling their best, they're not in their best shape, they're not their best presentation of themselves, they can suffer from mental health issues. Maybe they're depressed.
Uh-huh.
Have you seen any correlation? And I think I know the answer, but you're the expert. Have you seen any correlation as people meet these milestones and feel better and do more, that they have less depression? And if they're on medication for that, they come off of that?
For sure. I've seen patients, and I want to be careful about this answer. There are
Yes.
some people who have depression, and that's a chemical imbalance in their brain,
Yes.
and they need medication. And regardless of what their weight is, they're going to need medication to maintain that chemical balance, the same way that a diabetic needs insulin to
Sure.
maintain their sugar. But there are some people that suffer from a mild, low level depression that can be fixed with some self esteem, some motivation, some exercise. The body responds really well to exercise, and that improves the endorphins in our body, which improves our mental health. So I have seen patients where all of a sudden they're like, oh, I can move better, I feel better. I've
Sure.
had pain patients that I've been treating for 10 years that go on this medicine, lose some weight, and they're like, you know what, I don't need as much pain medicine. My knees
Right.
don't hurt as much, my back doesn't hurt. Well, pain
Right.
medications aren't great for your mental health either. They
Right.
affect a bunch of different things in our brain. So I have seen patients been able to kind of decrease some of their medicines, blood pressure medicine, cholesterol medicine,
Sure.
diabetes medicine, depression medicine, pain medicine, all of those, with taking medicines like that, losing weight, getting more active, and improving their overall well-being.
Absolutely, and let me add to that, so that we are careful with that. Obviously, you would work with their other their other physicians, their primary care physician, their mental health physician,
Yeah.
psychiatrist, or their psychologist to help make these determinations. We don't make decisions in a vacuum.
Yeah, correct. Yeah.
Okay, okay,
I'm not
yeah,
gonna
okay.
say, "Oh, well,
We wanna
you
be
don't
we
need your
wanna be
Prozac
careful.
anymore."
Yes,
Yeah.
we wanna
Yeah.
be careful.
Yeah.
Awesome, awesome. So I think that's great, and that leads me to this because I for me, I have a little bit of a holistic approach to my iteration of my practice. For a long time, I was just plastic surgery, plastic surgery, plastic surgery. And my point being, patients come in who want to have some change in their body. They've done all the things that, we talked about, exercise, so on and so forth. And they come to me thinking that some of the procedures that I have kind of equate to weight loss, which they don't. And so I say, to be in the best position for this type of procedure, you need to lose weight. And my answer was just that. I didn't have anything for them.
Yeah.
With the advent of, looking at the new mechanisms of action for semaglutides, now I have someone like you that I can send them to say, hey, you know, we have a plan. You're not ready yet. Doesn't mean you're not ready ever.
Mhm.
Let's get you on a good plan. Let's get you in the hands of a physician who is knowledgeable and experienced, and we can do this safely and so that you can meet your goal. So, having said that, are you seeing patients from plastic surgeons that are, that are sending you these patients beforehand, having surgery, and then they're meeting their goals and then moving forward?
The biggest place that I'm seeing, and it's not just plastic surgeons, it's all surgeons,
Okay,
orthopedic surgeons who say you need a knee replacement, your BMI is 40, and our guidelines say don't replace knees if your BMI is over 40. So let's get some weight off of you first, and then
sure,
we'll work on your knee. Plastic surgeons who are saying, you know what, if we could, I can give you the best cosmetic outcome, aesthetic outcome if we lose 15 or 20 pounds, then when we do liposuction or abdominoplasty, you're going to get the results that you want in your head, what you're envisioning versus what I can offer you where you are now. ENT surgeons who are working on patients for sleep apnea implants, that the guidelines say if your BMI is over 50 or 40, I can't remember which one it is,
sure,
that you're not a candidate. So I've got to get your BMI under this certain level before you're even a candidate for operating. And all of that ties back to that anesthesia question. Obesity is one of the things that we factor in judging your anesthesia risk. So if we can get
gotcha.
your BMI under 40, now your risk is way
Yeah,
much lower because abdominal fat pushes on the lungs, makes it
yeah,
harder for us to get oxygen in when you're under anesthesia. The chin fat is one of the things we look at when we're judging how difficult it's going to be to put in a breathing tube. So we get
yes.
some of that weight off your neck, and now your risk of us not being able to get a breathing tube in easily goes way down. So it all plays into that multimodal,
Absolutely.
look.
Absolutely. I totally agree with you, Doc, because we get the weight question all the time from plastic surgery. BMI needs to be certain amount, certain level, whatever it is, and it's different for different plastic surgeons.
Sure.
And a lot of it's tied in from our end to wound healing. Fat's a little poorly vascularized, so it doesn't really heal well. But I think we missed the global boat. You're not healthy. A
Yeah.
BMI may indicate a high BMI may indicate that you have some underlying cardiovascular disease. How easy is it going to be for you to go to sleep with all that weight on your chest? How can we manage your airway safely? So there's a broader perspective than just can I heal well. So, and this is when we have conversations between ourselves to make sure that we offer the safest
Yeah.
practices to our patients.
Yeah. And that's widely important. Another thing that I'm sure you've experienced, some surgery centers where we operate will have a BMI cutoff. If
Yes,
you're over 44 and then they all make up their own rules. There's not great guidelines from the American
absolutely.
Society of Anesthesiologists or the American Board of Plastic Surgery. There's like rough guidelines, but
Sure.
some of them say a hard and fast rule. We're not going to do your surgery at this location if your BMI is over X. And so that limits options for patients and surgeons to take patients to a place where they might prefer to go for surgery. And now I have to do you in a hospital that's going to be a different level of care than where I,
Absolutely.
prefer to operate.
Absolutely. Absolutely. Great stuff. Great stuff. So if somebody's on semi-glutides and they're cooking along, are there anything special they need to do? That they need to see you once a week for lab or blood work, or any alterations in their management that or need to be considered as they're kind of percolating through?
Great question. For patients that live close in Loganville, some people have needle phobias. Now it's a teeny tiny needle. It's an insulin
Right.
needle. It's a
Right.
31 gauge. I mean, it's nothing. You barely
Right.
feel it. But some people mentally are like, I can't inject myself. So if you live close enough to the clinic, we have patients that come in weekly and get their injection. Some people also like the interaction with my staff and myself and being able to ask questions while they're there. They like getting on the same scale, seeing the same reading versus, my
Sure.
one at home is three pounds different and I'm not sure if it's as good. So, they like coming in and having that. But I have patients from all over the state. So I have patients that live in, Woodstock. Well, that's a little far to come in weekly to Loganville.
Yeah,
So
sure.
we teach patients how to draw up the medicine, how to keep it
Okay.
safe, how to do it sterilely, a lot like a diabetic injecting their own insulin. But we teach them how to do that. But obviously, we're available by phone call if they like, hey, what should I do with my dose? I'm getting close to that point where I want to start lowering it, or I've stalled for a few weeks. Can I go up a little bit? So we work with patients on that to, fine tune their weight loss program so they can do it at home if they're comfortable with that, or they can come into the clinic.
Okay, perfect. And you don't really need and maybe I'm interpreting this wrong. Do you need to follow any particular blood work during that
No,
time? Okay.
some people will check, the cholesterol and liver panels, but the medication doesn't require you to check all those things. Typically, I tell patients, go back to your last primary care visit, look at your blood work, what it was then, and then when you go back in 6 months or in a year, let's see where you are. And in
Gotcha.
the meantime, if they want to have blood work, like, hey, I want to just check and see where I am. Obviously, I can run those panels if patients are really interested.
Okay, perfect. So it sounds pretty safe. You don't really have to check for any
No, there's
toxicities or any
there's no
problems.
toxins, right? No, it's a
Okay,
very,
perfect.
very safe medication.
Are there I had a question from somebody who jumped on, Robin. She asked, and I'm gonna ask a global question, I'm gonna drill down to her specific question. Are there any interactions with certain medications that you need to be aware of if you're on semaglutides? And specifically for her, any interaction with, ADH drugs like Adderall, so on and so forth?
So there's no drug-drug interactions. However, one of the side effects of these medications is constipation.
Okay.
So any patient that's already on whether it's pain medicine or ADD medications like Adderall, which are in the amphetamine class, those can cause constipation. Or if a patient already has underlying constipation, I'll go through, hey, we're going to have to watch this, and we may need to prescribe something. You might need to be more aggressive with your home regimen between Miralax and stool softeners and Senecot, hydration, making sure that you're not getting so constipated that then you're sick because you're not going to the bathroom effectively. So that's
Gotcha.
the number one place where I look for drug things, is looking at their other medication profile and saying, let's watch this.
Okay. Okay, fair enough. Cost, that always comes out. Is this
Yeah.
something that insurance companies can cover, or is this out of pocket?
Okay. So what I do in my practice, if patients are diabetic and they want to get on Ozempic or Manjaro, I normally will refer them back to the primary care doctor and say, hey, let's see if you can get your insurance to cover it. I do have
Okay.
a few patients that I'll write it for because they may be in between primary care doctors, but typically these medications are not approved by insurance companies unless you meet a lot of criteria. So you have to have a
Okay.
certain BMI, you have to have comorbidities, and then you prescribe it and they can't get it. The pharmacies don't have it. And so I have one patient who's on a 6-week waiting list to get his Manjaro.
Dang,
Um,
6 weeks?
6 weeks at the pharmacy. So
Wow.
what I am offering, what I have at my office is I purchase from FDA approved compounding pharmacies,
Okay.
and I'm able to get semaglutide and tirzepatide, and I sell those directly to the patient. So then
Okay.
they're so if your BMI is 36, you're not going to qualify, and you don't have hypertension, you're not going to qualify for the prescription through your insurance company, and so I sell that directly. What I do for my pricing, I have two plans. One I call the trial run. So if you just want to try it out, see how you do, see how you feel. The first 2 weeks are $60. That's the 5-unit dose to kind of just get your stomach ready for something different's coming. And then the
Okay.
next 4 weeks are $150. That's the 10-unit dose, where we really start to see weight loss.
Okay.
Or I've got a price where it's $500 for a vial of semaglutide. That lasts at least 12 weeks on the titration that I designed.
I see.
One of the things I do different than a lot of the weight loss clinics that are out there is I don't make people go up on their dose. So if you're
Oh,
losing weight
okay.
at 10 units, I leave you at 10 units. And so then your vial is going to last longer.
You're right.
I'm not trying to make you churn through vials so I can sell them more. I'm
Oh,
trying to get
okay.
you
Perfect.
healthy and
Yes.
well and lose weight and feel happy about yourself.
Right.
So sometimes, I would say for the vast majority of patients, that vial lasts longer than 12 weeks.
That's very reasonable. Okay.
Yeah.
Awesome. Awesome. Awesome information. Appreciate that. So let's say we're going to switch a little bit. Uh, Somebody's gotten through the end of it. They've lost a considerable amount of weight. Let's say 75, 80 pounds. Now I'm being a little selfish. I'm going to put in the plastic surgery part. Do you often have patients come and want to take care of, other things once they've lost their weight?
Of course. So, if you've lost 70 or 80 pounds, and I'll just speak personally, you've got that little apron of abdominal skin that kind of hangs over. And, I've used you as my own plastic surgery in the past when I had lost a lot of weight and had that skin taken off. So we call it a paniculectomy. So they're
Yes.
not, that you're just taking that skin off and kind of tightening it up. Women often see, some breast sagging after weight loss. You don't get to pick where your weight comes from. So women are
Sure.
like, I don't want to lose from up here. I'm like, we don't
Right.
get to choose. Weight's going to
Right.
come from where weight's going to come. And
Right.
so they come in and they're like, well, now I have this little flabby skin and I've got these kind of, my breasts aren't as full as they were before. What do I do? And that's where you come in and I say, all right, I've got your guy. I've
Right.
used him personally. I trust him. He's a great surgeon. He's a good guy. You're going to like this guy. Go see Dr. Stephenson. He can walk. He's going to look at everything and kind of walk you through options as far as getting you back to where you want to look.
I appreciate that, Mike. Yeah, the thing is, I want to make sure that patients know that wherever they decide to go, uh, if you got excess skin and you're not comfortable, still not comfortable in your own skin, if I can use that, you can have body contouring surgery. It's perfectly appropriate to have that to get you to that next level. If you have excess abdominal apron or excess skin in your tummy, breast that'll sag, you need to be uplifted, and hey, thighs and arms, those
Sure.
are big things as well. So that certainly is very reasonable. And that's something that typically insurance doesn't cover. I'm going to speak to my cost on my side because I think that's fair and being transparent. Typically doesn't cover. It depends on the carrier. It depends on the plastic surgeon. It may cover it in your insurance plan, but the plastic surgeon may say, I don't accept that.
Mhm.
So it typically falls in the realm of fee for service. And so that varies from patient to patient, depending on how much work needs to be done, where it's done, and the plastic surgeon's experience. So I can't give you a stark number, but just be prepared if you want that to come out of pocket, and it won't be typically covered by insurance.
Yep. But again,
So,
you're looking at an investment in yourself, right? I mean, we
absolutely.
we blow money all over the place in
No
this country,
question.
right? Like we all do it, right?
Right.
Like, oh, I want that
Right.
new iPhone. Well,
Right.
okay, am I still good with my iPhone 11? Can I not buy the new iPhone and then make that investment in me? And I know
Absolutely.
just personally that's huge when you look in the mirror after you get out of the shower and you go, huh, okay, that
Yeah.
looks better than it did. It
Right.
makes you feel better.
Exactly.
And I think
Exactly.
everybody can understand that, you know, weight loss is one part, but then what? And
Yes.
the media talks about Ozempic face and what I got this little extra
Yeah.
skin here. That's where you're going to come in and say, well, all right, what are the options here to kind of fix these things after my weight loss?
Absolutely, absolutely. That's great that you mentioned that. So, what's your experience been with the Ozempic face? And explain that from you, and I'll explain that from my end.
Okay. So I don't, it's funny because nobody would call it runner's face. I
Right.
lost 100 pounds one time running and I had the same face that I do now. But,
Right.
like we said, fat, you don't get to choose where the fat comes from. So you're going to have a little bit of skin hanging here. And so I grew my beard out, which covers it a little bit. Women
Right.
don't have that option.
Sure.
You may see a little bit of sagging here. That's where filler could come in. So rapid weight loss, you do see changes in your body. Skin is going to sag places where there used to be fat, and aging is part of that too.
Sure.
You don't have as much fullness in your cheeks as you age. We lose those fat pads. And so weight loss is going to exaggerate those things, whether that's weight loss from Ozempic or it's weight loss because you quit eating or weight loss because you were running.
Right.
So it does kind of get better over time. We see the
Okay.
body kind of even things out, but with rapid weight loss where we're losing 5 or 10 pounds in a month, the skin can't catch up with that. Yes, it's
Sure.
elastic, but it's not that elastic. So typically it's a short-term thing that over the course of several months or years, it's not going to look as drastic as it is. but people are going to notice. You're going to look at somebody and go, "Oh, yeah, you're on
Yeah.
Ozempic.
Yeah. Yeah.
You're on
Okay.
semaglutide. You're
Right.
losing weight because you're losing it fast."
Fast. That's great point. And, and that's one of the reasons why I don't rush to operate on people who've had significant weight loss, because there's going to be some type of evening out period, a steady period. I want them to get to that period so I really know where they are and where they're going to stay.
Yeah.
And so, yes, I agree with you. There is an Ozempic phase. It's just like you say, a rapid weight loss phase from whatever and whatever. So,
Yeah.
what I do for that is I try to wait at least 6 months, but typically a year. And then for the face, we can do filler, but typically the skin has been so stretched out and deflated that we need to lift, resuspend, see where we are, and then fill a resuspended balloon or a smaller balloon than a
Yep.
saggy balloon. Because I think in the case, if you try to fill a saggy balloon, you overfill it and it looks
Right.
unnatural. So that's
Right.
just my perspective. Every plastic surgeon has their take on it, but that's my perspective. But
But
there
that's why
are
you're an artist. I mean, you really, and you're a legit artist. I don't know if your patients and followers know that, but you are you can
I do
draw.
graphic art.
Yeah,
Yes, I
graphic
do.
art. So you're an artist both on paper and in humans. So you're looking again for aesthetically pleasing,
Correct.
outcomes. And so sometimes that is that. Let's pause. I know we want this, but let's work on a plan that's going to take, months versus, yeah, you've lost a bunch of weight. Let me jump in here and just do some things. You're looking for the best outcome for your patients, which I think is
Absolutely.
huge.
Absolutely. One of my favorite people in the world, I'll keep that name irrelevant. Always say the turtle always wins the race.
Yeah.
It's
Yeah.
slow and steady.
Slow and
So
steady.
when
Yeah.
we come up with a plan, we want to make sure that, like I said, we got the best outcome in mind for sure. Couple last questions just to finish it up. I'm gonna pivot completely a little bit. Talk about the wellness. We touched on that, and I'm interested in that just because I don't know, and I think some of my clients and some people watching who are not clients or either of us will know. We talk about IV hydration. I've seen IV hydration ads here, and somebody's throwing up a clinic there.
Yeah.
People who had a great night and need to kind of get
Right.
resuscitated.
Yeah.
They come
Yeah.
in. People who may have a little bit of brain fog and feel like they need to kind of freshen up. So talk to me about who's it for, how's it done, what's in it, and any pros, any cons.
So it's for anybody that doesn't have heart failure. So if you have heart
Okay.
failure, probably not a good idea for me to give you a bunch of fluids because the heart is you're already overloaded. So we
Sure.
ask about that. But typically it's somebody who's getting over an injury or illness, somebody who their diet is limited. So there are plenty of adults whose their diet is chicken fingers and pizza. I mean that's their only two things. So they're
What's
not
wrong
getting
with
a cut of yeah. But most of what's in IV hydration is B vitamins. And if you
that?
look at
Okay.
B vitamins, a lot of them are hard to get from our diet, in particular like B12. If you look at the foods that have B12 in it, it's mussels. So like clam type mussels, it's
Right.
organ meats. It's a lot of things that the modern diet really we don't eat a lot of. We don't eat a lot of liver and kidney and
Sure.
those kind of things. Unless you're living in Boston or Maine, you're not eating mussels, on a
Right.
regular basis. Tuna fish has one. I eat a tuna sandwich 3 times a year, but
Right.
that's not enough to keep my B12 up. So, a lot of those B vitamins are tough to get from our diet. They aid in weight loss. They aid in our cognition. They aid in kind of our overall body well-being. And so sometimes just getting a little boost of whether that's just a single B12 shot or it's an IV hydration bag of saline with B vitamins thrown in it. Also with zinc and some other micronutrients, just kind of gives your body that boost that maybe you're not getting because, you've been fighting an illness like
Sure.
COVID, or the flu or a stomach bug. And you know what? You're just like, hey, I need to replenish those things. I'll
Gotcha.
tell you, for me personally, when I get this liter fluids with vitamins in it, I feel like I'm 30 again for about
Oh
4 days.
man.
It just gives me
Okay.
this like, oh yeah, like
Right. Right.
I feel great.
I need to come see you.
Yeah,
You
it
need to put
really,
an infusion pump in me so I can feel 30 for about a month. That's all I
yeah.
need.
Yeah. No, it doesn't last. It's a short-term boost, but it also just doesn't drop off. It kind of peters out slowly as our body
Okay.
uses those resources. If I could do it, if I had the time to do it and sit down and do it, I'd probably do it once a month.
Okay.
But I'm running just like everybody else is. It's tough to
Sure.
find an hour
Sure.
to sit down in my own clinic and get an IV.
I understand that.
Patients wouldn't appreciate it if I was like, "Hey, I'll see you in an hour. I'm going to go back
Right.
here and get an IV."
Yeah, yeah.
Um,
I had a tough night last night. I need to I need to rehydrate.
uh-huh. Yeah.
That's awesome.
But I will tell you, like if we're going on a big trip and we're gonna do a little partying, if we're going to Vegas or
Sure.
whatever, I'll get an IV infusion before I go, and I'll get an IV
Okay.
infusion when I come back. It
Okay.
just
Awesome.
makes me feel good, and I'm young enough, healthy enough that my heart can take a liter of fluids with some vitamins in it,
Gotcha.
and just kind of helps keep me peppy, keeps
Gotcha.
me going.
Right. So if so in your process of your business, do you do like the initial evaluation for that, and then your staff does the ongoing infusions, or how does that work?
No, typically, literally, you can call my office and say, "Hey, I'd like to get an IV infusion." We're going to ask you those few little questions like, "Hey,
Sure.
allergies, heart failure, a brief little medicine list."
And you
But
come
for
on
the most
in.
part, yeah, just come on in. It does. We tell people depends on your veins. We use kind of a smaller IV, a 22 gauge.
Yes.
So we don't use a 20 gauge, which is a bigger IV. So it takes a little bit longer. I tell people plan on 45 minutes to an hour. We
Okay.
typically put you in a little dark room, turn on whatever music you like with
Right. Chill
Spotify
out.
or whatever, and just
Right.
let you chill and enjoy getting those fluids. And then you're in and out. Go
Perfect.
home and then just call us the next time you want one.
Perfect, 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 perfect. Well, man, this has been great. I mean, I learned a lot doing this, and it's been fantastic. And I'm so happy that you took a few minutes to come on with us, and I really appreciate it. I know that you've got a great practice, and I wanted to make sure that people knew about that. I think we have some synergies between our clientele. From my standpoint, if you come and see me and you're struggling with a little weight loss, I'm certainly going to send you to Dr. Kissel so that we can get a great strategic plan and we can meet your goal, and then we can do whatever you need to do. Heck, if you come to me and you just need something small and you're still struggling with weight and you don't ever plan to have plastic surgery, that works too. We can send you that way as well. So I'm really happy that we had this time and we can collaborate and we can tell people that we're out here and we can help, and we want to help. We want to make sure that people are the best versions of themselves and feel great.
Absolutely, I agree. I really appreciate you having me on.
Awesome, man. So if somebody wanted to come on and come to your office, so how could they do that? How could they find you?
So the website is socopainandwellness.com. The business name is Southern Comfort Pain and Wellness. Uh,
Okay.
Office number is 678-587-5993. There you go.
All
Um,
right.
Through the website, there's a link to make an appointment or just give us a call, and we'll get you set up as quick as we can, usually within a few days, get you in there and get you going on this journey.
All right, man. Well, you guys, I've known Dr. Kissel for a long time. He's a great physician. He's great, and I've worked with him in all aspects for all my patients. My patients have had, tremendous respect for him, and appreciate his art and his craft. And so, if you need any of these services, or you know someone who needs the services, I would call him. I'm going to go to him because I need to feel at least 45. I may not get to 30,
We
but
can
I'll
do
take
that.
40. I'll take 45, and I'll go see him. But all kidding aside, he's great. And so please, if you suffer from any of these things, or you want to change, or you want to lose some weight, or you just want to feel better, or you suffer from chronic pain from whatever medical or surgical issues, then he's the guy. So look him up. So Mike, I really appreciate it, man. Happy Father's Day
Thanks. You
to
too.
you, man, and tell your family I said hello. And let's do it again. Let's have you pop
Yeah.
on and do it again, and we can talk about some new things that are happening in health and wellness and weight loss. And so let's not be strangers.
Yeah, I'd love that. I think we could dig into some of your Exparel, some of your pain stuff too. I
Yeah,
think that'd
let's
be
do that.
awesome. I think your
Let's do
patients might
that.
enjoy hearing that.
Yeah, let's do that. Let's plan to do that. All right, man. We'll make plans for that. But otherwise, have a wonderful Father's Day and enjoy the rest of your weekend.
Thanks. You too.
We'll see you,
See you,
man.
Dr.
Take
Stevenson.
care.
Bye bye.
So, folks, I hope you guys have enjoyed this. It's a Saturday. I'm not going to call it a hot seat Saturday. I'm going to call it plastic surgery TNA. And that's not the TNA that you think. It's it's talking advice. So plastic surgery talking advice. And I like to have more guests on. It really could happen more frequently. I have some guests in mind coming up in the next 4 to 5 months, but it really happens if you support uh, this channel this live video. So if this is something that speaks to you, I just ask you to like it, share it with people who may benefit from it. It really will help me grow the channel because I really, I'm a doctor. I'm a plastic surgeon. That's what I do, but I'm still a doctor and I like to help. And so my footprint, a fingerprint in the world is to leave the world in a better place than I entered it. And the way to do that is to help other people. So if you're interested in helping this channel so that I can help other people, just simply like and share. Until next Saturday, you guys have a great weekend. And to all the fathers out there, happy Father's Day.